Fantastic. So let's talk about sulci and mucosal bridges. I work in Bombay Hospital, which is in Mumbai. And for anyone visiting Mumbai, please do reach out to me. It would be a pleasure to sort of host you in the hospital. So let's start first with vocal fold sulci. A sulcus is basically a furrow or a depression on the membranous vocal fold. I'm going to be playing a video which is going to show how there is almost an absent mucosal wave because of the multiple sulci this particular patient has, and also a phonatory gap which is present. So the voice is almost like a high-pitched whistle. Let me play the stroke. So what you're hearing, that sound, is actually what this young girl's sound is. And there are multiple sulci which are seen along both the right and left vocal fold and a phonatory gap. And because of this, the voice is really quite horrific because you have no mucosal pliability and you have a phonatory gap, and we have to do something to help these patients. And very many of them, at least in India, are very young because they have congenital sulci. And to live a life without a voice or such a hoarse voice is really decreasing the quality of your life. Now, sulci do happen to be the most challenging condition to treat in phonosurgery for benign glottic lesions, according to a lot of people, including me. What are the theories of sulcus formation? Boucher's theory basically is that it's a stage in the development of an epidermoid cyst. The hypotheses are that these lesions are congenital with anomalies of the fourth and sixth branchial arch during development. Also, the fact that you see cysts, sulci, mucosal bridges very often in association or combination with one another probably supports this theory. The long-standing dysphonia also probably is a clue in favor of the embryonic theory. However, we are seeing more and more what we would call phonotraumatic and maybe more superficial sulci, which are being picked up. Maybe this is now because of awareness, better equipment. Maybe they always existed, but we are picking them up now because we're aware of it. And there is some advantage in picking them up with stroboscopy. And I'll tell you why I'm saying some advantage. So the various classifications of vocal fold sulcus are: in 1985, this entity was first described by Boucher, and it was described as sulcus virgatur, which is along the length of the vocal fold, and sulcus vocalis, which is more like a focal pit. In 1994, there were two classifications, really, the Nakayama classification and the Ponte's classification, where there was an effort made to further define the type of vocal fold sulcus. So, for example, in Ponte's, there was an occult or a stria minor, which was the same as a type 1 of Nakayama, etc. And then a lot of us are familiar with the Ford classification, which was described in 1996. And this is basically a type 1 or a physiological sulcus, where you may see a depression, but the voice is good, the mucosal waves are good. And then you have the type 2, which is similar to the sulcus virgatur, and the type 3, which is similar to the focal pit or the sulcus vocalis. But what we found was that there were so many occasions where we had actually missed a sulcus on stroboscopy, and it was just picked up incidentally when we were operating for something else, like a polyp or a cyst. We were operating and we palpated, or under the microscope magnification, we picked up the sulcus. And this was surprisingly in almost 62% of our own cases, which went for surgery. So if we are going to miss so many sulci, probably because they are superficial, and all these patients were sort of preoperatively checked with stroboscopy, high definition stroboscopy, if so many sulci can be missed, then we can imagine how difficult it is to quantify the length and the depth of the sulcus even when we see it on stroboscopy, how difficult that would be. So we actually have then proposed a classification of sulcus, which is not in stroboscopy like the others, but under magnification of the microscope and with palpation and with, let's say, infiltration. And this proposed classification is very simple. A, B, and C are when the furrow or the depression is along the length of the membranous vocal fold, but it is 50%, that is half or more than half the length. And if the depth is going into the SLP, it's A. If it's going into the ligament, it's B. And if it's going into the muscle, it is C. Similarly, D, E, and F are those sulci which are less than 50% the membranous vocal fold length. Once again, D going into SLP, E ligament, F into the muscle. And then very often along with sulci, we may see mucosal bridges, which can be denoted as MB. You may sometimes have keratin accumulation within the sulcus or a cyst or a polyp within the sulcus. And that could be denoted as a KCP within brackets. Sometimes you may have a polyp or cyst on the opposite vocal fold. So this is just a diagrammatic representation of the same classification which has been proposed. And what is the primary reason of adding on to so many already existing classifications? This is a more specific classification under anesthesia where one is supposed to actually quantify the length and the depth, so that when we are describing a surgery for a sulcus and comparing it, let's say, to another surgery, it can be better compared if we are talking about the same type of sulcus in terms of the length and the depth. These are some of our own images just to show what we mean by the A sulcus or the D sulcus. So you see on the image, which is totally on the left-hand side of your screen, on the right vocal fold, there is a type A sulcus where you see the asterisk, and my microflap elevator is within the D sulcus, because as you can see, the length is less than 50% the length of the membranous vocal fold. Unlike this, on the left vocal fold, there are two type A sulci. So imagine this patient has got 4 sulci, so what the voice may sound like. The second image is an example of when we see a polyp emanating within the sulcus. So we've put P in brackets. Why do these polyps and cysts develop within a sulcus? I would say one of the theories should be that the body is trying to compensate the phonatory gap and is trying to create some kind of edema or lesion to fill up the gap. So maybe they are compensatory lesions, these polyps. So the third image shows a very much bigger polyp in now a D sulcus, because the length of the sulcus is less than 50% the length of the membranous vocal fold. And the final image is a left B sulcus. Why is it B? Because on palpation and infiltration, we found that the depth is into the ligament. So this is how we explain our classification. Coming to sulcus management, as I mentioned earlier, sulcus is one of the most challenging benign phonotraumatic conditions to treat. And therefore, when something is difficult, there are always different ways of approaching it. Similarly, for sulcus management, we have a plethora of epithelial change surgeries. So you can have sulcusectomy when you just excise the sulcus and then wait for new epithelium to grow back. Or you have the sliding down technique of Saito. You have the elevation and redraping, it described in 96. Excision of the sulcus, so sulcusectomy, but don't just leave it, suture the edges. Then the slicing mucosa technique described by Pontes and Belao in 97, and a pulse diglottoplasty described in 2013. We also have SLP augmentation surgeries. When the phonatory gap is very big, one may decide that we want to increase the volume of the voice by taking care of the phonatory gap rather than doing the epithelial change surgeries. So one can do injection with hyaluronic acid, and the latest one is silk, or fat injection or implantations, as described by Satloff. Fascia lata implantation, as described by Sunoda. Stem cells, also basic fibroblast growth factor. Hirano's group has done a lot on basic fibroblast growth factors as well as hepatocyte growth factors. And then you can even do medialization with Gore-Tex or Silastic, as described by Zeitels in 2003. So typically, if the phonatory gap is very large, more than 3 millimeters, medialization would probably offer a good increase in volume and, decreasing the breathiness to the voice. And unfortunately, very often a combination of various surgeries is needed. You may combine them in one stage, or you may want to do multiple stages. So this is something to talk to your patient about before you set out in treating them, because they should be aware that it is a challenging condition to treat. Now we do see very young children also with vocal fold sulcus. And so when I say we, I mean in India, and we've sort of documented this in a recent publication in the Laryngoscope, which we did as a multi-institutional study across Germany and USA and Australia. So we do in India see a lot of congenital sulcus. And, when we see children with nodules, you'll always want to conserve them, right? But sulcus is a condition, if you see in a child with hoarseness, it is, I think, something one should try to manage as soon or as early as possible. Because for some reason, the results are very good in children. Maybe it's better neuroplasticity. I have no proof of that. And what do we do is typically we augment the SLP and the paraglottic space with fat. So the child's own fat, and of course, we know that very often the fat may dissolve and you may have to do another fat injection, but it's something which I at least recommend in children. When I used to see adults with sulcus earlier, I used to do a lot of fat implantation, and even today, many people do fat or fascia lata implantations. What does this mean? So you take an incision, you see this patient has got a vocal fold sulcus, a linear vervature on both the vocal folds, and we are elevating the epithelium over the sulcus. Now over here, this is basically what we would call a type B sulcus because there was no ligament. And we've put pieces of fat, but if you just leave the pieces, the patient will cough it all out. So we suture it. So this is the implantation of fat. Another surgery which has been described is a pulse style laser glottoplasty. This was described in 2013, where the energy delivered is fixed at 0.75 joules, and each vocal fold is administered maybe 60 to 100 pulses. And I think this can be done in stages also. So this is something which has also been described for sulcus. And as I mentioned, for the deep sulcus, probably one can even think of sulcusectomy. These are some images showing you a right and left vocal fold sulcus. So you remove all the epithelium from the sulcus bed, both on the right and left side. And then you can take a 6-0 or a 5-0 absorbable suture and suture the edges of the epithelium, the medial lip to the lateral lip. And I'll show you this surgery video also. So here we'll see a small edited surgery. I hope y'all can see the video playing. If you can't, someone just give me a heads up. So we see over here and we can do the infiltration. That these are both type A sulci because they are more than 50% the length of the vocal fold going into the SLP. Now, what I'm doing is with an AccuBlade of a CO2 laser, I'm freshening or taking away all the epithelium from the sulcus bed, both on the right side as well as the left side. When we do this infiltration, it sort of splays apart the medial lip from the lateral lip and makes the bed wider and easier to operate on. Now we've freshened up the bed. So we've taken a 6-0 Vicryl. I'm holding it with a crocodile forceps, which has a lock and ratchet system. And we are suturing the lateral lip of the epithelium to the medial lip. Now, supposing the ligament was absent in the bed, I would take in my stitch not only epithelium, but ligament also, laterally and medially, so as to get the ligaments together. So scrunch it up to obliterate the space, and then they do better. So we do the same suture on the left side also. The patients really, they tolerate these sutures remarkably well. They hardly even complain of a foreign body sensation. And within 6 weeks, you see the sutures are sort of dissolved. And there isn't usually any granuloma formation with the absorbable sutures. unlike when we use proline. That, of course, is if we're doing a Wendler's glottoplasty, not in this situation. So as I also discussed earlier, you can have the basic fibroblast growth factors and the hepatocyte growth factors being injected. And Dr. Hirano's team has done a lot of work with both of these. And we've seen him very often talk about these in his presentations. And then you also have a combination of hyaluronic acid, alginate, hydrogel, and hepatocyte growth factor. And you can also use silk, which is a hyaluronic acid, which lasts much longer, almost 2 years. So various materials can be used besides growth factors. I would now like to talk about a surgery which we've been doing, I think now almost for 7 to 8 years, which we've called the laser-assisted sulcus release or the LASER surgery. How did I think of this surgery? I thought of it, I think, because of the Pontes and Bellau's slicing mucosa technique surgery, a very elegant surgery already described, as well as the triradiate incisions that one takes for subglottic stenosis. So we used to take, now we do a lot more of balloon dilation. I think a combination of these two led me to think of the LASER, and we've published our findings and paper in the Journal of Voice. But I'm going to take you through it. So initially, what we did is when we had these vocal fold sulci, regardless of whether they were A or D, the superficial ones, so therefore A or D, we did a release by making very small cuts, which you see with the red lines, very small cuts with the AccuBlade. And you see a small edited surgery on the left-hand side of your screen. So what you see now are the cuts taking place on both the medial as well as the lateral lip of both the sulci. The patient has got a type A sulci on both the vocal folds. So we have these small little release cuts being made, and intervening epithelium exists. And the idea of the surgery was that you're releasing the sulcus and you're also not creating a raw area at the anterior commissure, and you're keeping epithelium intervening. And because they're superficial, therefore the epithelium should grow back. And hopefully, if it grows in the same plane and does not dip down, then not only should the pliability improve, but also a decreased phonatory gap may be expected. So this is how we started the surgery using the CO2 AccuBlade system, where the length of the AccuBlade was made short, 0.5 millimeters, as opposed to 1 or 2 millimeters that we use. Depth always 1, which is 250 microns, and we were using it in super pulse with 10 watts. And then I'm going to just pause the surgery for a second. And then what happened is that sometimes we came across sulci where one lip was even deeper. Let's say it was going into the ligament and one lip was superficial, and we still went ahead and did the surgery, which means then we were making the cuts at 90 degrees into the ligament. Of course, one is going against the tenets of phonomicrosurgery because you're literally making mincemeat of the ligament then. But we saw the patients improve, so we started doing the surgery, and I'm showing you a video of a patient with bilateral type B sulcus. So if you see the image on the left-hand side, you see the pink color muscle directly in the sulcus bed because there is no ligament there. There's a hint of the ligament on either side, but the bed is pink, and this is the surgery of the same patient. She's a young girl with bilateral type B sulcus. That means the length of the sulcus is more than 50% membranous vocal fold, and it's going into the ligament. So now we're making 90-degree cuts, basically epithelium and ligament deep, and releasing the ligament. And the idea, the end of the surgery really is, instead of the depression, you should get a flat surface. Again, the healing, if it is in the same plane, then one would expect the results to be better. Now, how do we justify that improvement will take place when we are cutting the ligament? So what you see where we cut the ligament, there is muscle. So and we know muscle vibrates well. So I think what happens in the surgery is that muscle probably fills up the space and epithelium grows over it. So the same girl whose surgery I showed you, let me show you her preoperative. this is her preoperative strobe. You can see bilateral type B sulci, and that was her voice, hoarse, with a maximum phonation time of 10 seconds. I'm now going to play the 2-month stroboscopy of the same girl and then make you hear her voice also. So her maximum phonation time is double to 20 seconds, and we see a perfectly normal strobe. Now, this is our best patient. Every patient doesn't do that well, unfortunately, and we'll talk about the challenges also. But it's wonderful to get this result in sulcus, especially the deep sulci. So our study basically was on 17 type A, 8 type B, and 4 type D sulci. And when we compared the maximum phonation time, BHI and Grabas, pre and 3 months post, we had a significance. What was interesting was that this significant improvement was present even in the deep sulci, not just in the superficial sulci. What we also found was that in people who were under 21 years, the improvement was much more than people who were over 25 years of age. So the younger lot seemed to be healing better. The concerns with this surgery really were that we did not get a drop in pitch. So this became a big issue now for males, because for the females, at least in India, they don't mind a high pitch, even an abnormally high pitch. But of course, for males, that's a disadvantage. But now we found a way around that. I won't talk about it just yet because we've started doing some work regarding that. But the pitch with this surgery has been a disadvantage, and also the limited sample size, because we didn't take any patients of vocal fold sulcus who also had polyps or cysts, because then we would not know the vocal improvement is because of the cyst excision, how much is due to that, etc. So, the numbers get challenging. So in conclusion, we did get significant improvement in VHI, Grabas, and MPT at 3 months following LASR for both superficial and deep sulci. No patient worsened. I think that's very important, because in medicine, we always taught do no harm, at least, even if you can't help somebody. Large multicentric studies, of course, with long-term follow-up are recommended. Palpation of the vocal folds will reveal a sulcus in so many patients. In our study, 62%, in so many patients who you've missed it, even on stroboscopy and high-definition laryngoscopy. We will talk about vocal fold mucosal bridges now. This is an uncommon entity. There may be some people who've never seen it. So it's very interesting. It's just like a bridge. What is it? Basically, a thin band of mucosa which runs parallel to the vocal fold, connected anteriorly and posteriorly, not to the free edge of the vocal fold. This is a mucosal bridge, but is it always thin? No, it can be thick too, in which case it's not epithelial only, but there will be a central axis of connective tissue surrounded by stratified squamous epithelium. What are the theories of formation? According to the theory of Boucher and Cornut, a mucosal bridge arises from 2 apertures in a single epidermoid cyst when it ruptures superior and inferior. The second is genetic. The third, it could be because of vocal fold microtrauma. So here I show you a patient who's got dysphonia. And you see that there's what we call a hemorrhagic cyst over here. But to be honest with you, we did not pick up a mucosal bridge on stroboscopy. We took the patient up for surgery because of this hemorrhagic cyst. And it's only during palpation that, we picked up that there's a thin epithelial mucosal bridge. Now, what will you do when you identify the thin bridges? I think you can excise them or you can leave them. The verdict is really not clear. Nobody really knows whether it is of benefit. There is a hypothesis that dysphonia may be due to separate vibratory characteristics of the mucosal bridge from the main vocal fold, because the mucosal bridge is thin and the vocal fold is thick. So you may have both of them vibrating, aperiodically, and you may have diplophonia or dysphonia. But there haven't been enough cases to get a gold standard as to what to do for thin epithelial mucosal bridges. So I'm sorry, I don't know either. I used to excise them, I tend to keep them in situ now. The thicker mucosal bridges, where you have not just epithelium, but connective tissue in the core, leave them is my recommendation. Don't excise them. Here you see two polyps on either side of this thicker mucosal bridge. Why leave them? Because the volume of the vocal fold basically will just decrease, and then you'll be struggling to inject fat or do some kind of a medialization or augmentation to thicken the vocal fold. And these vocal folds, believe me, can get the mucosal bridges, can get really thick. As you see here, on the right vocal fold, we've got a bilobed polyp, hemorrhagic, and it's on palpation again on palpation. This thick mucosal bridge, I completely missed it. And because you've got the polyp sitting there too, so how are you going to see it? Both the big polyps were attached to this thick mucosal bridge. So of course you remove the polyps, but leave this thick mucosal bridge intact. And it's very interesting when we see this patient post-operatively. I'll show you the video pre-operatively first. This is the same patient. So of course we can't see the mucosal bridge because we're seeing the polyps. But very interestingly, if you see the second image, and I'll play it in just a second, but we can actually identify the point of cleavage, and we can see the mucosal bridge separate from the vocal fold. It's even more interesting because you realize that if you had removed that thick mucosal bridge, how thin the right vocal fold would have become. I'm just going to play it for you. So you see where it stops now. You've got, this is the point of cleavage right here. But what's also interesting is because the mucosal bridge and the vocal fold are almost the same thickness, if you see the stroke, the amplitude and symmetry is excellent. No phonatory gap, symmetrical mucosal waves, fantastic amplitude, but you see that point of cleavage. The patient didn't have any whistling sound, was extremely happy with his voice. So palpation of the vocal folds during surgery is an integral part to diagnosing not only mucosal bridges, but also vocal fold sulcus. Now, during routine vocal fold palpation, occasionally we were finding a slit on the vocal fold superior surface. And when we put the flap elevator, it would travel. It wasn't like a sulcus. It would travel all the way to the medial vibrating edge and then just stop short of exiting from the medial edge. So these entities we found were distinct from sulci, which are just depressions. They don't have a hood of epithelium over them, and we call these incomplete mucosal bridges, and we've published this in the European archives in 2019. So to describe this, on the right vocal fold there is a cyst and there's some secretion sitting on top of the cyst, but on the left vocal fold we see that there's a slit. That slit, if the instrument goes in, it's sort of going all the way. It's almost like a mucosal bridge, but literally an incomplete mucosal bridge. It's just falling short of exiting through the laryngeal introitus. So this is what we've called the incomplete mucosal bridges. And maybe this is an indicator of how mucosal bridges develop, and further research is maybe needed in this area to understand how mucosal bridges really develop. What do we do for them? Here's another situation. And the left vocal fold, I call it a fried egg appearance, where you have this open cyst lying within a focal pit. But on the right vocal fold, you see that little slit. Put an instrument through it. That's a flap elevator. It goes all the way in. I've not done any surgery on the right side. Falls short of just exiting the laryngeal introitus. So one surgery which either you just leave it Again, no gold standards because we don't have enough cases, but you can either leave it, or what we do very commonly nowadays is freshen the opposing surfaces, the whole bed, as not only the bed, but the undersurface of this incomplete mucosal bridge, and then suture the edges together. So that's what we've started doing for this patient. Had bilateral, left side was an open cyst and right side incomplete mucosal bridge. So you could excise it, mucosal bridges, you can excise them. I recommend the thicker ones, please don't leave them untouched, but you can freshen the opposing surfaces and glue them together or suture them together. PDL glottoplasty with mucosal bridge undermining has also been described by Chang et al. In 2016. Now, just to coming to the end of the talk, really. What do we think this is? I'll pause it for a second so that you can hear me. Initially, I thought the patient had an anterior glottic web. But keep looking and you will see that actually the patient has a mucosal bridge which is flopping around anteriorly, giving the impression of a web. So it's actually a mucosal bridge which is present attached to the left side and not an anterior web. And here is a very unusual situation where you actually see a dramatic mucosal bridge on the left vocal fold, which is literally flapping during the stroboscopy, the aperiodic mucosal waves. This patient had been biopsied on the left vocal fold in South India. So I don't know if this is an iatrogenic mucosal bridge or whether it was present because of the disease, which we found as laryngeal sarcoidosis. That's what the patient had. And after excision of the epithelium, he was treated with steroids and is doing well. So this is extremely unusual to see a mucosal bridge during stroboscopy. So in conclusion, thin mucosal bridges may be excised, but the thick ones should probably not be excised to avoid the loss of bulk to the vocal fold. More research definitely is needed to set gold standards of care in mucosal bridges. Incomplete mucosal bridges are seen as slits. Palpation is needed. It's recommended that all patients undergoing microlaryngoscopy be actively palpated for the presence of sulci, mucosal bridges, even sometimes small cysts. This is vital basically for the accurate identification and documentation of lesions responsible for the patient's voice quality. You may not want to do anything about it, but it helps to document why the patient's voice is slightly hoarse or slightly breathy. So I hope that this has been of interest to you. And I'm just sharing the QR codes. One is of our annual phonosurgery workshop. One is of my YouTube channel on which I have some videos and I try to keep adding to those. I would also like to take this opportunity to invite all of you all to the 19th workshop on phonosurgery, which is being held from the 19th to the 21st of December. And we're very excited. Professor Satloff is visiting India for the first time. We had amazing international faculty. Dr. Karen Koss from Montreal, Dr. Marina Madbaki from Malaysia, Dr. Tetsuji Sanuki from Japan. So each one of them is going to be talking about something very interesting. Of course, professional voice will be Dr. Satloff's main theme. Dr. Karen Kost is going to be telling us a lot about aging voice. Dr. Marina Vatpaki is going to be talking about the voice prosthesis, which is the latest one, which you can sort of add on, increase the volume or decrease the volume of the implant. And Dr. Tetsuji is going to be talking about the titanium T-shaped implant for type 2 thyroplasty for spasmodic dysphonia patients. And we're going to have the hands-on laser in CO2, in the blue laser. We're going to have all the framework surgeries, injection laryngoplasty. So I'm going to stop sharing.